Lady turned left in front of me. I could not stop the time. I ended up hitting her backhand. A few days after the accident, my shoulder really started to hurt. My dad suggested I get a lawyer. I got Frank Azar. Frank Azar took care of everything. He was strong enough to get me $125,000. Everybody in Colorado knows that if you're hurt in a car wreck, you call me, Frank Azar, the strong arm.
Tracy, it looks like you don't have mute on. Something's playing in the background.
Trip to the ER. But now the big insurance company
primary role is to facilitate the subcommittee and the task force meetings for the Behavioral Health Task Force. And as you can hear, we have people on Zoom. We're trying to fix the feedback a little bit. So it will be important for those of us who are in the room, excuse me, to be cognizant of the microphone when you're making comments. We have some master mics, which did a decent job last time, but if there's going to be a direct comment, I'll try to run the mic. And then Shannon has a lavalier mic that we can also pass, but it just makes it easier for people who are on Zoom to be able to hear us. So for those of you on Zoom, when you're ready to participate, you can either chat in. We have Emma Gilchrist who is monitoring your chat comments, and you can also pipe into the room just verbally. If you're on phone only, to unmute yourself, you have to hit *6. Just unmuting on your phone won't let you into the Zoom room. You have to actually hit *6 on your phone. And so I think that's kind of the housekeeping around Zoom. And just welcome everybody. We're really happy that you're here. And I'm gonna pass. Well, objectives for the day. I'll do this first. We're here basically just to get kicked off with this children's subcommittee. You are the final kickoff meeting, and we're really, really excited that the children's group is coming together to kind of get on into the meat of this work and why we're all here. So we're going to do a lot of level setting, spend some time doing introductions, and then really get into some of the readings that were assigned as pre-worked for the team in getting here. The co-chairs will be going through some of that, and we'll have an opportunity to have some discussion around kind of where we're headed as a subcommittee, and then move into the weekend. I should have put that as an objective. So with that, I'll pass to our co-chairs, Shannon and John, who are going to welcome the crew, and then we'll get busy.
Welcome. I am thrilled to be here, and I'm thrilled that all of you are here, that you've set aside this amount of time. It's a lot of time, and some of you have driven a very far distance. And so we're just excited that we have been able to assemble an amazing group of folks. Just a little bit about myself, since I probably am the least known person in the room, I would think, at some point. I am now currently working for HCPUF. I am the ACC Pediatric Behavioral Health Liaison. I came to HCPUF in January after working for 5 years as an embedded clinical social worker in pediatric primary care practices. And so my career here in Colorado has been primarily working in integrated care, and out of a community mental health setting, working with these primary care practices to establish and get pediatric behavioral health access to various markets around the Denver metro area. Before that, I've actually worked in child welfare in another city. All of my professional career has been with children, and so I just consider myself very lucky and fortunate to be here today, and I'm excited to see what we can accomplish. I think if I had one sense of passion for myself, for what I'd like to see accomplished, as a provider, it was very frustrating for me to support families, to work with families, to get them the services they needed. And so I definitely am bringing a provider lens to this conversation. And I work in Green Valley Ranch at one point here in the Denver area, which straddles 3 counties. So you can imagine 3 county mental health centers, depending on address and school and medical care. The complexity of our system is not helpful. And neither is this microphone. Is it working? Awesome.
I think it's just very sensitive to and
okay.
Movement.
further away.
Thank you.
You could clip it on.
So
Yeah, you can clip it on too. That's the distance the lavalier is sort of going to be responsive to.
So coming with that lens to this conversation, and I think moving into the state position that I'm in now, one of the dreams I had was that we could reform the system, and lo and behold, we have a governor and a new administration that is called for such a thing. And so how exciting that we can be here at this time to do that. One little metaphor, if I can, that's just been rolling around in my head. You know, we've been charged to think outside the box, and I've had a sandbox in my mind, you know, thinking of kids. And I know it's not a common vision in Colorado, But if we could think outside the sandbox and decide to go to the beach instead, you know, that there is capacity, there are things that we could accomplish to that degree, to that extreme, to that, you know, imaginative, to that aspirational. That's how I'm approaching this task. And so thank you. Thank you for your expertise. Thank you for your years of hard work to do this very thing we've been asked to do. So welcome.
It's going to be hard to follow. So yeah, I just wanted to thank everybody so much for being here, for joining together. I think together we're going to be able to try and really make a meaningful change for Coloradans and for the kids and families that we serve. My name is Shannon Van Diemen. I'm the Vice President of the Pediatric Mental Health Institute at Children's Hospital of Colorado. I'm also the Executive Director of Partners for Children's Mental Health. As for why I'm here, so we were asked to explain a little bit about that, what brought us here, and also why collectively we think we are all here. And so personally, when I was 14, I actually had some involvement with child welfare. And I did get expelled from school at one point in time, and I had to rebuild my life. And it was amazing to me at the age of 14 to realize how fragmented the system was. And I remember saying to my friends, I was like, this thing is seriously messed up. And when I grow up, I want to like try and help fix that so that other kids don't have to go through the same thing that I had to go through. And so I feel very fortunate that I've got to spend the majority of my career actually doing this type of work. I've gotten to work with a lot of state and local agencies, provider organizations, advocacy organizations, and youth and families across a lot of states across this country to try and do these types of reforms. Unfortunately, there's not like a single place where we can be like, it's fixed. We're done. There's nothing more for us to do. But we are making, I think, incremental improvement. I think this task force right here gives us a prime opportunity to really make some meaningful change in Colorado. In terms of like why we collectively are here, I think we're all aware that we have a little bit of a crisis in our children's behavioral health system in the state of Colorado. The Mental Health America releases a report every year on the state of mental health in America. If you look at that from a prevalency perspective in Colorado, for mental health, we're ranked 45th. In the 2019 report, and for substance use, we were ranked 49th. And so we know that we have a huge amount of need here. One of the good things about that report is we did actually see some strengths in that though. In terms of like youth access to care, we were ranked 10th. And in terms of workforce capacity, we were actually ranked 12th. So we do have some providers here. So then the question becomes like, what's the gap? What is it that we need to be fixing? So we can use some of that data to help drive us. I'm sure that everyone knows that in Colorado, the leading cause of death among 10 to 24-year-olds is suicide in this state. Related surveys in schools have shown that 14% of youth admit to having or self-report having made a plan to commit suicide in the last 12 months. 8% admit to having made a suicide attempt. This is something that we see at Children's Hospital of Colorado. So we've actually been tracking for a while the number of admissions we have to our pediatric intensive care unit because of suicide attempts. And this isn't something that they talk about a lot. We talk about suicides, but we don't talk about suicide attempts. We've seen a 600% increase in the last 8 years. And so we used to have fewer than 20 youth admitted to the ICU at Children's Hospital because of suicide attempts. And now we're at over 125 on an annual basis. And so this is a crisis that just looking at suicide numbers alone would not actually give you the visibility to in terms of the things that are going on. The last statistic that I'll give you, and then I'll stop with my statistics, is I think a lot of you know that of lifetime cases of mental illness, 50% of those begin by age 14, 75% by age 24. And so I think that's why having a really well-functioning and well-designed children's mental health system is the ultimate early intervention prevention strategy. So I think that our subcommittee is the best subcommittee by far because we have the opportunity to intervene and to make a real difference. And so I want to echo what John was saying in terms of us thinking outside of the box. I think we can get as big and radical as we want to. And so I've had people ask me, like, coming in, what are the changes that you want to make? And I'm like, I don't know. It depends on how radical we want to be. And, you know, there's some states that have created new state agencies like New Jersey. In Florida, they have carved out the children's behavioral health benefit for Medicaid, and they administer that differently. And I'm not saying either of those are things we should do, but I'm just giving those as examples of like the level of changes that we should be thinking about in terms of what do we need to do to make the system work better for our kids. And so with that, again, thank you. I'm excited to be here and to work with all of you.
And Shannon, we heard you on CPR this morning on our drive into work, and I'm sure the comms team had something to do with that too. So that was really exciting to hear about the work of the Children's Subcommittee on and NPR this morning. So you did a really nice job. I was impressed.
Thank you.
Oh, and we have Director Barnes, who has joined us via Zoom. And I think she wanted to welcome the group as well. So Michelle, if you can unmute yourself, we'll be able to hear you in the room.
Good morning, everybody. I hope you can hear me. Good afternoon.
We can hear you.
Great. I'm very sorry I'm not there in person to meet all of you. I'm in Routt County at our State Board of Human Services meeting, but I will be listening in for the next 3 hours and chiming in as appropriate. And I look forward to listening intently with what you all have to say. So thank you for agreeing to volunteer all this time and all this effort. I can tell you the other task forces have already launched, and it's the best part of my week is to join because there's so much enthusiasm and bold thinking in terms of making life better for people in Colorado. So very thrilled to be joining you by phone, and have a great day.
Great, thank you for joining us and saying hello. So I just wanted to briefly introduce the Farley Center team. As I was saying when we were doing some housekeeping, our primary role with the Behavioral Health Task Force work is to act as facilitators for the meetings. So you'll be seeing us here. We are adamant timekeepers, or we really try to be. You'll also be hearing from us probably between meetings because, as you know, these are happening really, really quickly, and there's work that we're going to be working beside you to complete between those meetings, and some of those communications will likely be coming from the Farley Center. So I'm Stephanie Kirchner. They give me the mic the most because I'm kind of the chattiest, I think, on the Farley team. But we've been doing this work with stakeholders in other states around different reforms in their Medicaid systems. We've been working in Oregon, we've been working in Virginia, and we couldn't be more excited to have the opportunity to do this kind of stakeholder engagement and convening work here in Colorado, where we live. So we're really excited. So Emma Gilchrist is Deputy Director of the Farley Center. She's here manning Zoom, which is a full-time job during these meetings, trying to make sure all of the technology is working. I'm sure at some point in the next 12 months, all of us will be on the other side of this. So I beg your patience as we go through inevitable hiccups with Zoom, but Emma's here to handle that. And Kayla Ross is here with us too. She's taking minutes today for us on behalf of the Farley Center. And Shale Wong is coming. She's our director. She's also a pediatrician at Children's, and she's on her way. She kind of got tangled up in a little bit of traffic on her way from Anschutz, so she's on her way. So we're just excited to be here. Emma, do you want to add anything?
No. All right. Can't wait to see what we do together.
Okay. So one more bit of housekeeping before we get going. You'll notice that around the room we have stick sheets on that say parking lot. There's 3 of them in the room, and I've put sticky notes around the room. What we have found, this is sort of an early learning from the other subcommittee meetings, is that there's a lot of discussion that goes on and a lot of concerns that emerge that aren't necessarily completely related to what we're trying to tackle in the moment. Doesn't mean they're not important, doesn't mean we don't want to come back to them. So we're using this parking lot system to be able to gather that information. We can use it to plan future meetings, find out about who needs to be here to speak as a subject matter expert, concerns you're having. And so you'll find us directing you to the parking lot if we're finding that things are kind of starting to go off topic. So please don't be offended. We have sticky notes for the purpose of gathering those thoughts so that we can make sure we're able to be responsive to them. So I think that's it on the parking lot. And now we want to get introductions from all of you. And so we have preserved some time to go around the room and make sure everybody is starting to get to know each other. You're going to be spending a lot of time together over the next 12 months, both virtually and in person. And so we just want to know your name, who you're representing, and really what are you most passionate about related to children's behavioral health. You've heard from Shannon and John kind of the answers to this question, and we're just looking for short introductions to make sure everybody has a chance to be heard. So can I start here since the mic is here? And we do have these mics in the center, but when we're doing this kind of things for those in the room and on Zoom, it's just best to pass the mic.
Good afternoon. My name is Catherine Wells, or I go by Kathy. I am a child abuse pediatrician. I'm the executive director of the Kemp Center, and I'm at the University of Colorado, and of course, I'm affiliated with Children's Hospital Colorado. My interest in this work is really grounded as a pediatrician first. I was a general pediatrician in a small community for 5 years, and then elected to do child abuse work. And clearly the relationship between trauma, early childhood trauma, and children's behavioral health, and child abuse and neglect, and kids that are in the system, whether it's through child welfare. Thanks for teeing that up. And the complexities related to that, or the legal system, often are intertwined. And so it's really hard to do the work I do and continue to do without understanding the true importance of children's behavioral health and how we improve that for our kids. So I'm glad to be here. It's an honor to work with all of you, and I'm looking forward to it. Thank you.
Hi all, my name is Carol Meredith. I work for the ARC of Referral in Douglas. We're an advocacy organization for people with disabilities. I'm most passionate about creating a system that's actually systematic, that you wouldn't call an oxymoron. From the ground level, I have a son who was on the autism spectrum, who also has multiple mental health diagnoses and has had since he was like 14. And I work with families all the time who are trying to access the system. And so I echo the frustration from the provider level. If in 30 years, if I can't figure out how this works, maybe it doesn't work and we need to fix it. So that's why I'm here.
Good afternoon. I'm Leslie Patterson. I'm a counselor by trade, but I do a lot of program development. I started a recovery high school down in Colorado Springs, and I started Springs Recovery Connection, which is a community organization to help people facilitate where they can get substance use information. And I was also a supervisor for counseling department in a high school, in a school district down in Colorado Springs. So the biggest thing I ran into was families coming to me and saying, where can I get fill in the blank? And really there weren't a lot of resources for the family. So I started doing a lot of research on what was available in Colorado. And I'm not originally from here. And I was a little discouraged on the services that were available. So started creating some of these programs to help families, because they were coming to us and saying, where can I send my child for treatment? And recovery high schools have been around the country for probably 30 years, and it just was an amazing opportunity to bring resources and mental health and substance use into the school district, into the school, so that it was a one-stop shop. So thank you.
Hi everyone, my name is Lindsay Myers and I'm with the Colorado Department of Public Health and Environment. I oversee the Violence and Injury Prevention Mental Health Promotion branch there, and we house several programs I think really touch on this issue. We house the State Office of Suicide Prevention, a lot of our substance abuse prevention work for opioids, for marijuana, alcohol live in my branch, as well as the Child Fatality Prevention System, which touches on a lot of these issues. And newly, the Healthy Kids Colorado survey, which I know you're all familiar with from the reading. So lots of connections in our work. I think our branch tends to focus on upstream prevention and really looking at how do we build protective factors within individuals, but also within communities and systems, so that everything is connected and people feel supported. And so I'm really excited to be part of the group.
My name is Megan Burch, and I'm the Director of the Department of Human Services in Eagle County. And I think I'm here to represent the rural voice in this issue, as our access to services are not always equal to what's available in more metro urban areas. Also, I believe that bringing the rural in touch with families and the family voice perspective into the work that we do as well. And for our community, that means a very large Latinx population that is not part of the system at all as it is currently built. So just making sure that we keep that family voice and the clearly underserved and most vulnerable populations in mind.
Hello, I'm Morgan Bruss. I am a school psychologist practicing in Harrison School District in Colorado Springs. This is my 8th year practicing, 3rd year here in Colorado. When it comes to children's mental health, I'm most passionate about looking at a child through a whole child perspective. A child is not just a son or a daughter. They're not just a student. They're not just a child with a disability. They wear a lot of hats. So in order to address their needs, we need to look at them through a variety of lenses and using a variety of strategies.
Hi, I'm Sam Field, and I guess I'm representing two things. I run an outpatient program with Mile High Behavioral Health Care for 18 to 25-year-olds, young adults coming out of homelessness, struggling with substance use and mental health. And then I also run a private practice where I specialize in working with the LGBTQ population, and I would say that is where my passion and expertise is. So I'm really excited to be here.
Good afternoon. My name is Lisa Zipprich. My current role is as Director of Special Education for Fountain Fort Carson School District, which is just south of Colorado Springs. And by training, I also am a school psychologist and practiced for many years prior to this role. I think in terms of who I'm representing at the table here, as I hear about child abuse and social services and special education and mental health, the schools are really the place where a lot of that, the legal system, where all of that plays out. Our school district has the largest special education population in the state, a big part of which is due to the fact that almost 70% of our students are affiliated with Fort Carson Army installation. And with that comes a unique perspective that our students are bringing to school as well. And so seeing all of that hash out in our setting and just accessing the community pieces, making sure we have the right pieces in our schools and the supports that just don't quite fit, that we just can't quite get in some way is something that I'm passionate about fixing.
Good afternoon. I'm State Representative Daphna Michelson-Janae. I'm elected to serve here in the Colorado House of Representatives, representing Aurora, Commerce City, Brighton, Bennett, Keensburg, Strasburg, a little bit of Thornton. Anyway, it's a lot. It's all within Adams County. And I currently serve as Vice Chair of our Public Health Care Committee and Chair of the School Safety Interim Committee. And I'm most passionate about suicide prevention. Ultimately, I believe that if we look at the whole child, as we've heard mentioned by a number of you, and we get upstream of suicidality, that we could turn around our abhorrent suicide crisis that we have with our youth and with our adult population. And in the School Safety Interim Committee, it's very interesting because I'm looking at legislation right now already, but really I need to hear from all of you before that legislation moves forward. So you're gonna have to talk really fast and we're gonna have to work really hard because you only have 5 minutes. No, I'm just kidding. What we're looking at and understanding is only 2% of our youth are dying by violence in school. 98% of them are dying out in the community. And if we don't look at resources and services in our schools that leak out into our communities, then we're not going to solve the problem in school. And even if we just solve the problem in school, that's only 2% of our youth. What about those other 98? So how do we look at that holistic approach? And my biggest issue, and we're kind of doing it here, is we've got too many silos. And by the way, hello, welcome to the silo for today. So how do we break down these silos and make sure that all of our agencies are working together so that we have the most efficient use of our very, very limited resources? Because, you know, a pot here, a pot there, a pot there, you're gonna do this, I'm gonna do that, we're gonna try the other thing, and we're not making progress. So how about we break down all the silos, figure out what we're all doing, and take the best and make that work.
Hello, I'm Dawn Kadirian. I am a 6th grade teacher at the Vanguard School in Colorado Springs. Although I am not here representing Vanguard, I am here because I have firsthand experience with a child who has struggled through the system. I have a almost 17-year-old daughter who was first diagnosed with depression in 2nd grade. And we know what it is to try and find providers and to try and get everyone coordinated and to try and find the resources to cover all the things that are not covered. And when we are in those places, I see people that don't have the resources I have, that don't have the choices I have for my daughter. My daughter is fine today. But there are so many people who couldn't try all the things. We've tried everything anybody told us to try. We did it. And there are so many people that come to me. I started a blog because it was just therapeutic for me. That was when she was hospitalized last year. And through that blog, so many people have come to me wanting to know, what do I do? How do you find these people? My child just did this. How do I get him admitted? And I tell them, here's what I did. And he said, we can't afford that. So I'm here to represent the families that are looking for ways to help their children.
Hello, everyone. My name is Melissa Yaniszewski. I'm representing the City and County of Denver, the Mayor's Office of Children's Affairs. I have a hybrid of a background. I'm a social worker by trade, but I've worked in public health for over 10 years. My passion is really thinking about how do we reduce barriers and delays for young people as they transition into adulthood, really thinking about trauma-informed care, making sure that they have wraparound services so that they're not left behind and that they have all the resources that they need.
Hi everyone, I'm Rebecca Swanson and I'm here today representing Stephanie Villegas and the Child Protection Ombudsman Office. We, as Kathy mentioned, we work really closely with the system, both child welfare and the Division of Youth Services, and really we have so many calls that intersect with behavioral health and mental health and substance use issues, and this is something we're really interested in working on. Previously, I came from Mental Health Colorado, so I recognize a lot of you from there, work with Lauren Slater and others on some mental health legislation, and Representative Wiggles and Janae. And then from a personal perspective, I have a child who recently started treatment at Children's Hospital and at Kaiser simultaneously, and I was told initially that he would have an 8 to 10 month waiting list to get into this treatment, and he was in crisis. And because I knew the right people to call and I knew my way through the system, we were able to get him in within a week for his initial consult, and now he's in full-time treatment within the first month. And I want to make sure, like you said, that this is available for every kid in the state and not just for people who know the system.
Hey, I'm Cecile Fraley. I'm a pediatrician and CEO of Pediatric Partners of the Southwest down in Durango. So I think I'm representing rural and frontier for the Western Slope. Our practice serves about 10,000 kids. We were molded in the Steve Poole model of pediatric medical home, and we're about 6 years into integrated behavioral health delivery with our folks being trained actually by Steve and Islet at Children's Hospital. We have, in addition to our clinic and serving as hospitalists, we also have a school-based health clinic in Bayfield in Durango and a frontier tele clinic in Silverton, which is more frontier for Colorado than most places. I think I would say I'm super passionate about the delivery of behavioral health care in partnership with the community in a pediatric medical home. We have been really excited about the kinds of things we've been able to do, offering services to our kids through the 6 counseling sessions plus. And then we have the biggest partnership with Children's Hospital in the state for tele services with over 25 subspecialists, but one of our most beloved is that we have a tele psychiatrist in Kim Kelsey. We're heading into our 4th year with Dr. Kelsey. And for us, when there's really been limited services down in Southwest Colorado, it's been dramatic. So I'm passionate about getting upstream, about supporting families, but also identifying families with social determinants of health, and would love to see things de-siloed. We can kind of work around that sometimes in a small community, but would love to see some of those barriers drop down and services pick up for families.
Good afternoon, my name is Raoul de Villegas. I'm a psychologist by training. I serve as the secretary for Mental Health Colorado, as well as wear multiple hats throughout the Western Slope. My primary role these days is to serve as a consultant in the Western Slope, and I work mostly with behavioral health integration in primary care settings, work with wraparound services with community agencies, also work with workforce development, which I think is a huge thing for outlying areas to attract folks, train to make sure that they know how to handle things in kind of a sparse area when it comes to resources. I do provide some direct care to children, and also work directly with the school system because we know the importance of having prevention work within the school systems to begin with as a good source of information and sort of an area to catch kids as we identify those issues in the classroom. So There's lots of things that are happening in the Western Slope, especially in the Grand Junction area. We are working on a school-based health center as a potential here in the next couple of months. And so for me, the passion is the integration of all of these services. Because as we probably all know, you cannot treat an individual child without treating its community, and that means its family, its support system, and obviously the community at large. So to think about things without the integration and thinking of things in terms of silos seems to be part of what got us to this point. So I'm excited to hear that we are not doing that any longer and moving forward as a team. So it's a pleasure to be here.
Hi, I'm Lindsay Robinson. I'm with Jefferson Center for Mental Health. I'm the Chief Operating Officer there. So I believe that I'm sitting here to represent community behavioral health. But I will tell you that my background started there at community behavioral health, where similar to some of the things that you guys have already said, I've seen as a provider numerous issues with trying to get kids and their families the care that they need, particularly when they have complex presenting issues that go across a number of different backgrounds, or whether it's something that would intersect with you, Carol, or a child who has just presenting issues in the school. There are a number of things that you guys have already touched on that really speak to me around breaking down the silos. The one thing that I do want to say, I don't believe, though, that we do have a mental health system. I think we have a mental illness system. And so I hope that what we will focus on here is how we identify, whether we use the term upstream, whether we talk about resiliency, whether we are thinking about adverse childhood experiences and what kinds of prevention tools we need to put into place. My hope is that the reason we have such a broad array of individuals sitting around this table that are not behavioral health providers to address behavioral health in children is because we're going to think outside of the box. We're going to go to the beach, as John mentioned, and we're going to think about who else needs to be involved. This can't just be on schools. It can't just be on community mental health centers to solve this problem. This is a Colorado-wide issue, and I'm really, really thankful to be here with all of you guys with different perspectives, and I'm hoping that we can do some really good work.
Hi, I'm Andrew Gabor. I'm with the Ops Behavioral Health. I'm the Director of Child and Adolescent Services, and I'm filling in for Camille Harding, who's the Director of Community Behavioral Health. So I'll only be here for today and then be back occasionally. So the Ops Behavioral Health, we have many different programs for many different children and families, and working at OBH for a while now, it's been exceedingly difficult to make sure that the community knows about the programs we have. There are good programs out there, there's good services out there. No, they're not throughout the entire state. That's a huge issue. But then where they are at, people don't know about them. And how can we make sure that we leverage the services and the funding that we currently have? And how can we help children and families access services regardless of funding source? There's so many, and again, this goes back to what everyone else is saying, there's so many different silos in the state. How can we really break those down? My dream for this group is that how can we, yes, work outside the box, work on the beach, and how can we really make sure that every child in Colorado, regardless of where they live, regardless of income, how can they get really high quality behavioral health care? So thank you.
Hi everyone, my name is Jessica Peck, and best I can tell, I'm the only lawyer in the group, so hopefully you don't use that against me. But I have a friend over here in Shannon because, like her at 14, I was a little hellion. I didn't get kicked out, but probably should have, and as a result, I've dedicated the rest of my life to all the hellions who aren't quite so lucky. My law practice focuses primarily on family law, and really what it's evolved over time, because my personal passions is ensuring that we have due process at the intersections of parental rights, student rights, disability, and education. And it's an incredibly challenging and rewarding time. I'll tell you right now, I probably represent 6 or 7 families whose children have taken their own lives within the last year, including
It was at Arapahoe High School, Cherry Creek. There was a 9-year-old at Denver Public Schools that represented his family. And when you find out that children are killing themselves or taking their own lives, I know that was a political slip there. When children die of suicide, when they're victims of suicide, it at such a young age that the government does not even keep statistics on that, then we have a real problem and how quickly these lives are being lost. And I just this morning was in court on behalf of 2 families who were seeking protection orders from their own children because their children's mental health issues are so untreated that they are seeking, or that these children have lived in a constant state of homicidal ideation or have, in one case, attempted to kill a sibling within the last month. We don't have the resources to put these kids in residential care, congregate care. And so what is happening is these kids turn 14 and they enter our juvenile correction system and ultimately our adult prisons. And that is the tragedy to me. And the biggest tragedy of all of this is how many calls I get a day from people saying, I mean, I must have my name on some bathroom and in some high school somewhere, or there's some chat group for parents in crisis, because there are no lawyers doing this type of work. And that is a problem. And we need to make sure that our law schools are investing in making sure that we have attorneys who can really work, protect the rights of parents and students and kids in crisis. So I will just say to any of you, if you have any resources in terms of what I can do to help these families who are going through our legal system in crisis, because right now it's very much patchwork. It's what one county DHS is telling me versus another versus another.
Hi everyone, my name is Jennifer Grody. I'm the Director of Integrated Behavioral Health Services at Denver Health, and I oversee all the behavioral health services that happen in our community health clinics, both for mental health and substance use counseling. And we have 30 people on my team that are providing services in 15 clinics. And what we're doing in the primary care setting, I think, is an amazing opportunity to give patients and families access to care and a point of entry, because most families will bring their kids to the doctor. They will not always bring their kids to a community behavioral health center. So I think we have a really great opportunity, but we are limited in the services that we can provide. And we often act as a consultant or provide a bridge to those community services or higher levels of care. And we find that those systems are, as everyone is saying around the table, very siloed and often broken or hard for families to access. So I think that I'm here to represent both federally qualified health centers, which Denver Health has 9 of them, and the patient and family voice in the primary care setting. So I really want to take these opportunities to help grow our connections and understand really upstream how we can solve some of these problems. I work across the lifespan as in my clinical practice, so the adults that I see probably could have benefited from services when they were kids. So I think we all want to keep that in mind and try to figure out ways that we can help, even from the maternal mental health, starting there, and working with early childhood, birth to 3, and on up the spectrum. So thank you.
Good afternoon. My name is Lindsay Reeves. I am the Director of Early Childhood Programs at Catholic Charities in Pueblo. And I think you just teed that up perfectly, thanks. But really being able to, I also oversee our Launch Together initiative, which is really a systems building initiative around behavioral health and early childhood. And I think one of the most surprising things to me when I started in this work was the fact that we have children being expelled from childcare and preschool. And it's still flabbergasts me to say that every single time that I say that, but it's the reality. And I think that provides a lot of the passion for me to be able to look, excuse me, to look upstream and realize that I truly believe that a lot of the impact that we can have can be rooted in early childhood. When we look at creating that systems level change or that culture change that it's going to take, early childhood, I think, is where we start. So I'm excited to be a part of this group.
Now we'll go to members of the subcommittee who are joining us by phone. Emma, I'm going to let you maybe manage the order since you can see them.
Adrian, can you please unmute yourself and introduce?
Good afternoon. Can you hear me?
Yes.
Oh, wonderful. I am Adrienne Maddox, the Executive Director of Denver Indian Health and Family Services. I am here today to represent our Native American community. We have been in the community as a health clinic since 1978. We serve a unique community with high rates of trauma with children, adolescents, and into adulthood. Our American Indians continue to die at higher rates than other Americans in many categories of health disparities. So I feel it is important to educate and inform key stakeholders and working with our community in a culturally sensitive manner. I am honored to be on this subcommittee, and I look forward to serving in person on the next meeting.
Thank you. Brooke?
Can you hear me?
Yep.
Wonderful. Hi, everyone. This is Brooke Gracie. I'm so sorry to not be there in person. I tore my calf muscle playing tennis 2 days ago and was so looking forward to seeing you all. I look forward to seeing you at future meetings, but was not able to hobble in today. I am honored to be serving on this subcommittee. As a clinical psychologist, I've worked in my career as a practitioner, a researcher, an educator, and a nonprofit administrator. Most recently leading Judy's House, which is the nonprofit comprehensive grief center that I co-founded over 17 years ago with my husband, Brian, in memory of his mom who died. We're a community-based center. We provide free counseling, group counseling, and individual and family therapy for children 3 to 25 and their parents and caregivers. We also have a large-scale research initiative, and we train the workforce through internship and education and efforts and awareness and advocacy work. Through this work and just through part of being a part of this community, I've become very passionate about what we've talked about. I'm so excited to hear more people talk about upstream prevention. I'm excited to jump into that beach with you all and on my crutches and really think about how we can not only wrap around the whole child, but the whole family and take that more whole community approach to the care that we provide for those who are identified. And we obviously need to do a better job of identifying and getting early intervention in place. But that piece of prevention, of recognizing the profound impact of ACEs, of adverse childhood experiences. My early career was focused on child abuse and neglect and domestic violence, and then moving into the bereavement area, I've really come to appreciate how powerful it can be to empower and strengthen families and children with healthy coping skills and resilient, adaptive tools that they can use to not only navigate the challenges they're facing, but also live life in this crazy world that our youth are growing up in. I'm a mother of 2 young kids, one who's 13 and now really having to deal with what social media and technology and the crisis of suicide that we are experiencing. We had a suicide in our own school recently, and I've been involved in the suicide prevention aspect of the work here. So I'm excited to hear everyone talking about how can we not only ensure access to care for those with identified conditions, but to get ahead of it and provide preventive interventions that can and that are covered by insurance or some other entity so that folks don't have to wait until they have a diagnosable condition to receive effective care.
Thanks, Brooke. And Jamie Murray.
Hi, my name is Jamie. Can you hear me all?
Yep, can you speak up just a tiny bit though?
Okay, so my name is Jamie Murray. I'm a school psychologist representing Canyon City School District. We're in the southern part of Canyon City in a rural area. And I guess it's kind of difficult for me to pin down 1 or 2 things that I'm passionate about. I'm just passionate about kids. And after 19 years of working in the schools, I just see so many barriers for kids advocating for themselves to get behavioral health supports, whether it's family roadblocks or insurance issues or just lack of resources. And even when we have those resources, that people start out real strong and then kind of leave the area and go somewhere else. So I would just I'm just so excited to hear everybody's feedback and kind of where we are as a baseline in terms of the state and how we're going to move forward and problem solve over something that's extremely important for our youth.
Thanks, Jamie. And Aaron Miltenberger.
Hey, so my name is Aaron Miltenberger. I'm with the Boys and Girls Clubs of the San Luis Valley. I've been doing youth-based development for the last 25 years, going back to working in programs for youth advocacy in the 1990s, working in adjudicated youth programs in Phoenix, Arizona, and wilderness therapy programs, some of the only wilderness therapy programs that were publicly funded instead of privately funded in the state of Colorado in the early 2000s. Currently working with youth advocacy, socio-emotional learning, and workforce development in the Boys and Girls Clubs of the San Luis Valley and a number of other youth-serving organizations, mental health-related organizations in the Valley. I'm really honored to have heard all of your incredible introductions. I feel like I could echo lots of things that were said. I really appreciate those folks who care about young people have used asset-based language, talked about problematizing the system instead of problematizing people, and looking for a non-siloed based solution to trying to move the needle on supporting mental health in young folks.
Thanks, Aaron. And we have a number of members of the public on the line as well, and a few phone numbers I'm not recognizing, so I'm just going to quickly call out to see if a few of our remaining subcommittee members are on Zoom and or the phone. I just didn't catch them. So Sarah Davidon.
Here representing her. She's on a plane right now.
Okay. Would you like to come? Okay. Rebecca Hia. And Shannon Seacrest.
All right. I just want to say that that went really smoothly, Emma. So I feel like I should jump up and down for you. And Robert has been in every single one of these meetings, and I think maybe you would second that this is the smoothest that Zoom has ever really worked for us. So it's good. So with that, I want to just do a couple of housekeeping things that I failed to do as we were gathering. One is around the restrooms. The men's room, if you exit this room and go to the left, you have to go out kind of what looks like an exit door. And then you have to have a badge to get back in. We're currently missing the badge. Where is it? Aha. We'll put it over, we can put it by summer. And then, so you just need it to get back in through, you have to scan it to get back into the building. Ladies' restroom is past where you came in and around to the left. And I just want to make sure that we absolutely welcome the members of the public who have taken the time to join us today. We are glad that you're here. We want to be able to include you in small group discussions that will be coming up later in the day, and we'll help you to form a group to be able to provide your input. And also there's time protected at the end of the day for public comment. So we'll be able to make sure we hear from you at the end of the day. And then I also wanted to make sure we introduced Summer.
Hi, everybody. You've heard a lot from me, and you'll be hearing more from me later on today.
And then Shale Wong, who's the director of the Farley Center, who is joining us. Just want to make sure you have an opportunity to introduce yourself too.
Hi, everyone. It's actually really nice to see some friends in the room, some that I haven't seen in a long time. I'm Shale Wong. I am the director of the Farley Health Policy Center. I'm a pediatrician by training. And, you know, I just want to say we feel incredibly privileged to be working to facilitate the Behavioral Health Task Force and these subcommittees. This is an area of work in terms of integrating care and integrating behavioral health in particular that the Farley Center on the whole is deeply committed to. And we've had, as we've mentioned, some opportunity to do some of that work in other places. So I'm really happy to be with our own family here and community here in Colorado. And then for me personally, as a pediatrician, to finally get to the children's subcommittee. It's been sort of long awaited, so we're pleased to get to work and really dig in today. I'll just add, you know, personally in terms of passion in this area, as a general pediatrician, I've been doing behavioral health work for more than 20 years without formal training in that space. And I've been, you know, deeply blessed for the last, I don't know, I think 17-ish years to have an integrated team in our practice. I don't know how to do it any other way at this point, depending really on my partners and that team-based approach to begin to address the issues. And it's just not enough. As great as it is in primary care and with some of the medical home models that we're working on, it's a fantastic entry point. And then I go home and I'm now up to 7 calls in the last 3 years from people outside of work who have contacted me personally saying, can you help me? Because it's a friend, it's a relative, it's somebody who's saying, we don't know where to go. And that's when I'm really feel like I'm at a terrible loss. And there's one thing when I'm in my clinic and I kind of can grab my partner. It's another when in my personal life, which happens, I think, probably to all of us. You get those calls, and in that moment, how do you help those people who are dearest to you? And those are people who found somebody to reach out to. We gotta have something. We have to have everything that's better than that. So I deeply appreciate all of the starting comments here, and I'm eager to get to work. Thanks.
I also wanted to recognize the communications team. You'll be hearing from them directly later on, but they're joining us in the room as well today, waving from over there.
Hey, good afternoon, everybody. I just want to, Michelle kind of touched on this, but the communication from the governor and executive committee, which is the lieutenant governor, Kim, the executive director, Hickpop, as well as Jill Ryan, who's the executive director at CPHE, and Michelle, has been everything's on the table. Like absolutely everything's on the table, legislatively, budget-wise. I just want to reiterate that everything is on the table, and I don't feel like you have to piecemeal or anything like that. Put what you think is the right system for us to be a leader in this country on serving kids and families. And I just want to reiterate that everything's on the table. Great.
So in order to step into the space where we can do what Robert's asking us to do and really put everything on the table, it's important for us to do a little level setting around the fact that this is hard. Working together is challenging, and I'm sure many of you have sat on subcommittees, have been in work groups before. We don't all come to this from the same perspective. We don't all share the same lens. We may not always agree about what is the best outcome, but that's kind of why you were chosen to be here, is to be able to voice that in a space where you can feel heard. We, in our experience, have found that that's what most of the time people find most important, is not necessarily getting their way, but feeling like their way was considered. And so we're going to be working really hard to foster a space in all of these subcommittees where that is the goal. So it's okay to voice a different opinion than the co-chair. It's okay to disagree with the person sitting next to you and walk out with a strong professional relationship with them. And that's the kind of thing we want to foster and really encourage amongst you. Some of us wear multiple hats. You've already described that. We're professionals, we're parents, we're siblings. We have our own personal experiences that we're bringing into this work related to really thinking about how the system works. And so I think that all of those are important to describe. As you're coming to opportunities when there's a vote at hand, it is important to kind of be thinking about what perspective you're bringing forward in terms of really looking at recommendations and what we're going to put forward as kind of the outcomes of the subcommittee. So we just encourage you to be thinking about that and how you're expressing some of your feelings and work as we get closer to those kinds of decisions. We also understand that business models could be affected, which is part of the reason why we all have different perspectives. Some of us may have something to lose as systems change, and we have to be willing to embrace that in order to make sure that what we come out with is a system that we really want to see grow and thrive to serve the best that we can in Colorado. Some of us have history. Some of you have probably worked together before. Shale's already got friends in the room. And so trying to figure out some of those things and how they work for us in a positive way, and also kind of realizing that some of that history comes into play in ways that can feel a little uncomfortable, I think is important just to just to call out. And hopefully we can, again, foster an opportunity for some of those things to be handled and those difficult conversations to be able to occur in a place where we can walk out all feeling like we've accomplished what we set out to do. So with that, we have drafted some operating agreements or some group agreements, and they're on the slides that we printed for you. If you can't see them, I'm trying to get out of the way for Lindsay. But trying to recognize that and come to the work with charitable assumptions that we're all trying to do good work, even though we may disagree. We're all here because we want the best for kids in Colorado. And that it's important for all of us to be heard, which in some situations may mean that those of us that are more vocal need to be willing to step back. And it's something that as facilitators will be watching for to make sure that all voices are included in a way that feel meaningful and feel heard. Important to be tough on ideas, but not on people. It's okay to be constructively critical of other people's ideas and trying to figure out where we can all meet in the middle somehow, but it shouldn't become personal. Again, we talked about acknowledging role and what hat you're wearing as we move through this process together, and to stay really solution oriented. We're going to really try hard to start and end on time. I will say we're ahead of schedule right now, which feels really good. It's Friday afternoon. And then, you know, just using words thoughtfully and being respectful. I have 2 kids who started school this week, and I feel like we went through this at the dinner table. It's kind of, I think most of this is pretty, is how we feel like we want to be treated and how we try to treat others, but sometimes we just need a little nudge to be reminded. So I want to open it up for a couple of minutes to see if there's anything that we've missed. You certainly can add to these. We could take away from them, but so usually there's a couple of things that float out that people are like, oh, let's add this, and then we'll make sure those are reflected when we gather again in a couple of weeks. I saw someone peeking. Are you okay over there? Yeah, okay. Anything to add? You guys are really in Friday afternoon mode. You're like, nope. So if you think of something, you know how to find us. You can send us any of your further thoughts through email or put them in the parking lot too if you think of things later in the meeting.
Can I make one?
Yep.
So as we've mentioned, we've done a few of these kickoff meetings, and one that has come forward, and I saw you stand up, and so I think this is what you're going to say, and you can correct me if I'm wrong, is just the importance of using person-first language and keeping our families and communities and patients and consumers at the forefront of what we do. And so that's one that hasn't made it into the slide deck because we pulled the slide out from other ones, but I think it's a really important one that we will incorporate and feed back to you when we meet again.
Does that spur any other thoughts? All right, I'm going to pass to Summer, who's going to go through a few other logistics and expectations so that we can move in quickly, hopefully, to really getting some work done together.
Great, and good afternoon, everyone. Happy Friday. I'm excited to be here with all of you. Before we jump into the logistics, I just wanted to share a little bit of my background since you've been getting numerous emails from me and updates. So I am a numbers nerd. I'm a former CPA that quickly decided that public accounting wasn't as exciting as I thought it might be, and quickly left the private sector to work with homeless and low-income individuals and really help them get education and training and into the workforce. And quite frankly, it's probably my first exposure to working with the public and individuals who had various behavioral health needs. I was living in DC at the time. I did that direct service work for a number of years. I started a workforce nonprofit and ran that. And then back in 2007, DC elected a new mayor, Adrian Fenty, and I was recruited to run the DC Department of Labor. So I also got the huge government agency experience and what that looks like and what that means. And then I did the typical DC thing, which is leave government, go into consulting. So I did that for a number of years, moved to Colorado in 2012, which was the best decision I have ever made. And started consulting. And my first consulting project was actually with the Denver Foundation when they received $40 million to launch the Colorado Health Access Fund. And I served as that first project manager. And when we went around the state and talked to all these different communities and said, what is the biggest need in your community? What's the biggest health need? Behavioral health went to the top every single time, which is why that fund, we decided to really focus on behavioral health. And I worked with the foundation to help them form their grant making strategy, get that project off the ground and start making those investments in the community. Since then, over the past couple of years, I worked with the Colorado Health Foundation on their behavioral health strategies. I worked with NAMI down in Colorado Springs with some of their strategic planning, just various groups. Last year, I worked with CDHS on the Crisis Steering Committee and helped to facilitate that process. As I'm not shy about saying, it was probably the hardest project I've ever worked on, and that includes being harder than DC government, but also the most rewarding one at the same time. So I think that's just a little bit of background for you to know. One of the reasons why I'm so excited to be in this role and kind of helping to lead and support the Behavioral Health Task Force and the subcommittees is because, as you've heard Robert say, as you've heard Michelle say, there is real willingness all the way from the top to figure out how do we have a behavioral health system that works for everybody. And that is all the way from the top. And as Robert said, everything is on the table. We are in a really unique position, and we need to make sure that we take every advantage of that opportunity. I often talk about the fact that when I came into this role a couple months ago, I started talking with others and said, what other state has figured this out? Who's doing this really well? What I hear is Massachusetts is doing this part well, Washington State is doing this part well, Virginia conquered this piece, but there's no state that I've heard that has a comprehensive system. So what I want to see is in a couple of years when people say, what state figured it out? That they say Colorado figured it out. And that's where I want us to be. It's going to take a couple years. So I just want to be really clear on expectations. This is a planning year. We're going to have a blueprint in June of next year, 2020, that we will deliver to the governor. And it's going to be a little bit different. So one of the great things I think about where we're starting from in terms of the subcommittees and the task force is that there have been lots of reports and research and data that has been gathered over the past couple of years. And we've been culling through all of that. And that's one of the reasons why we shared some of those pre-reading materials with you, which we're going to talk a little bit about later. That gives us a really strong foundation from which to start. So we don't need to go back and look for more data and more research. There might be a few things that pop up that we say, yeah, we need to get some more stuff on that. But we have those recommendations and those strategies and some of those goals. What I want to do in our blueprint is take that to the next level. So what are we going to do in year one? What's reasonable? What does the budget mean for that? What's the staffing? What's the public policy? And who's going to do it? So in year two, no one's looking at each other saying, oh, I thought you were going to do that. Oh, I thought you were going to do that. It's going to be really, really crystal clear. So we've got that accountability in place. And that's really where I want to see us when we deliver the blueprint to the governor. So it just gives you a little bit of kind of background and my philosophy. Any questions about any of that before I start going through logistics? Yes.
So the timeline is problematic for the legislature. We'll have bills come out from School Safety Committee this year. We'll have bills come out from the Healthcare Committee. What I'd love for your thoughts on is there an approach that I could be directing where we're starting to get bills that are aiming in the right direction and setting us up for the success of whatever comes out of the blueprint. That might be a tall order, just a request to put on the table.
That's a great request for those of you on the phone, just make sure everyone heard. We're just talking about the timing and the legislative session that starts in January, knowing that we're not going to deliver our blueprint until June of 2020. So as we've been thinking about this and developing the work plan, we're hoping to potentially have some preliminary recommendations to start considering in December. So our legislative team has started doing some analysis to kind of look at the legislation over the past couple of years, what that has meant, what the implications have been, how do we need to think about that work differently. I'm not going to sit here and promise you that, yes, we are going to have definitive legislation that we're ready to put forward in the next session, but we have it very much on our radar and we're thinking about that timeline.
We will have definitive legislation to put forward. I just want to make sure it's...
Yep. Yeah. So I think that to the degree that we can help inform that, we would be very willing to. So thank you. Any other questions before we go into logistics? Okay, moving forward. So we're going to talk a little bit about the expectations and guidelines document that we asked you to sign. So we'll go into that momentarily. We did circulate the boards and commissions training. So again, if you haven't taken that, please go ahead and take that. Just gives you a sense of kind of some of the rules that we need to know in terms of being on a public subcommittee and task force such as this. And then in your folders and packets that you received today, there's information about travel reimbursement. So if that is something that you need, you've got some guidelines in there that you can follow as well. So I think you guys already all know this, that there are 3 subcommittees supporting the work of the task force. The 3 subcommittees right now, children's, obviously, which hopefully you all know by now, this is what you are on, children's, safety net, and long-term competency. This is the starting point, right? This is where Governor Polis said to us, these are the 3 subcommittees that we want to start with the task force. This is not the end all be all. And that's a great, again, this comes back to everything's on the table. We have the ability to be creative. We have the ability to be adaptable. If we need to think about combining committees, subcommittees at some point, if we get into this and say, we really need to focus on fill in the blank, we can add another subcommittee, we can have work groups. There's all different options that we have. That being said, I'm going to also come back to, let's be realistic. We're not going to be able to fix our entire system in the first year. So let's be really just thoughtful about how we're approaching this work and starting to prioritize. So that's a little bit about how the subcommittees will play into the task force. So all of this, each of the subcommittees will bring formal recommendations to the overall task force for consideration. Shannon and John serve as ex officio members of the task force. So not only are they here at these subcommittee meetings that we're having twice a month, they are also going to the task force meetings and reporting to the task force, here's what we're doing in the children's subcommittee, here's what we've talked about, here's our formal recommendation. And then it's up for the task force to like look at all these recommendations coming out of the subcommittees and say, great, that makes sense, let's connect this, what are we missing, where are the gaps, and what are the priorities? Like, so what are we gonna tackle in year 1 versus year 2? So that's kind of how this is all flowing up, just to give you a sense of kind of the workflow. Any questions about that? Yes.
I guess I have a quick question around the definition or I guess scope of this committee. Are we looking at youth 0 to 26 to 18? I think that's important for other committees to know if that we need to focus on. Another committee needs to look at 18 to 26-year-olds and this group only going to 18. So is that up for discussion?
So that's a great question. So one of the, just for those of you on the phone, the question was, we need to define specifically, especially for this work group or subcommittee, what's the age range that we're looking at? So we're going to talk about that. And that is something that we will discuss and decide upon as a subcommittee. So that's a great example of Shannon and John might go back to the task force and say, okay, we're going to look at 0 to 18. And then safety net saying, oh, well, we're looking at 24 and over. This is just a hypothetical. We're looking at 24 years and older. So task force can say, hello guys, there's this 18 to 24-year-old gap. Like, what are we going to do about that? So that's a great example. And I'll tell you that the safety net subcommittee, they're actually in the middle of having their discussions right now on defining what is a safety net. What do we mean by that? So all of these initial kind of meetings are setting some of those definitions and expectations so that we can share that across subcommittees and figure out where are those gaps that we need to address. That's a great question. Other questions? Okay. So you all have received the expectations and guidelines document. Because this is the last subcommittee to kick off, what I will share with you that I have found is that everyone's been really great about turning these in. And then I'll get a question around, well, how does the voting process work? Which is laid out in the expectations and guidelines document. So the reason that we put this together for all of you is because one, we just wanted to be able to start right out of the gate and say, this is how we're moving forward. Two, we want to be really clear. This is a heavy lift. Like, this is not a great, nice thing to put on your resume and say, oh, I was part of this work. This subcommittee is meeting twice a month. In between those meetings, we will be doing work. So this is going to be a pretty heavy lift for the next year, and we want to be really clear with all of you about what you're getting into. So that's why we asked you to read this and study it. I will not quiz you on it, but I will be able to tell you if you have not read it. So I will be on to you. A couple things I do want to just highlight because these are questions that have been coming up. If you're unable to attend a meeting, you have the option to identify a substitute or proxy. So what that means is that if you are here representing an agency, an organization, you can't make it and you want to send somebody else from your organization, that's fine. You just need to let us know ahead of time. And that person can vote for you as well. If you want to have a proxy, you can use that as well. And what that means is that if you're on the subcommittee, you know that we're taking a vote that day, you can't make the subcommittee meeting, but you trust one of your fellow members enough to vote on your behalf, they can do that as well. So you can set that up. Again, we just need to know that ahead of time, so it's not happening in the meeting. Formal decision making, that'll happen through motions, seconds of motions. So really, if we want to put forth a formal recommendation for vote, somebody would say, I make this motion, somebody says second, we open it up for discussion, and then once discussion is done, we take a vote on it. The vote is simple majority. So in order for us to be able to vote, we have to have a quorum, which is just 50% or 51% of the subcommittee. So we need to have at least 14 people here. And then 50% of whoever is voting, is the vote that we go with. So in the chance that we do not have a unanimous vote, which could very well happen, those of you who are voting in the minority, so if you're saying, nope, I'm not in support of that vote, you do have the option to write up kind of your response, your point of view, and we can include that kind of in the addendum of the final report so that it's still, that your voice is still reflected in there. So that's an option as well. Any questions about any of this? Okay, it is Friday afternoon. Okay, so I'm going to shift gears a little bit. Community conversations. So one of the things that we are really committed to as part of this work is making sure that we're getting out and about across the state and meeting with different stakeholders as well as family members and consumers and asking for their recommendations and suggestions and ideas. And we're calling these community conversations. They are, what I would say is, they look different in every community. So there's been some communities that I've gone to, such as Eagle County, they already have a meeting once a month. And they said, hey, Summer, it'd be really great if you could just come to that. So I had a chance to go to Eagle County and be there with Megan and some great people in the room. Other communities have said, we don't have a regular meeting. We know who we would want to have in that room. So they've gone ahead and helped with the logistics. So it looks different in every community. What we want to do is, so there's one of me. I can only get output so far. Our executive committee, which is CDP, the executive directors of CDHS, of course, Michelle Barnes, who you heard from earlier, CDPHE, HICPUF, County Representative Barbara Drake from Douglas County, our County Commissioner, Division of Insurance, Mike Conway, and our Lieutenant Governor, as they are getting out and about and traveling across the state, they're also having community conversations. What we are also asking is that all of you have community conversations. And we don't expect you to do that alone. What I would say is we will circulate the roster so you can see not just on this subcommittee, but on the other subcommittees and the task force, who else lives in your area or region so you can band together and do these in groups of 2 or 3. And we're gonna have a training. So later on this month, August 21st, and we'll send out the calendar invitation on Monday for all of you. It will be recorded, but we will do a webinar training just so you have a sense of what does this look like? How does it flow? What types of questions are we supposed to be asking? And we'll go into much more detail then. I just wanted to give you all a heads up that that training will be happening and that we are asking you all to kind of get out in your communities and really have some of those conversations. One of the things I'm really clear about is that this cannot be just a check the box, oh, we hit every corner of the state. This is a genuine opportunity to engage with stakeholders in your community and really get into what recommendations do you have, what suggestions do you have, what else should we be thinking about. Raoul, I've been in Grand Junction twice now, I'm wondering, do you have anything that you would want to add in terms of what you've observed so far?
I think just very briefly, one of the things, briefly, I think one of the things we've identified is that there are a lot of individuals who are doing lots of great work in a siloed fashion and individual fashion. And so to have the community conversations be a source for us to get together under this bigger umbrella of this blueprint plan is going to be significant in terms of efficiency and also aligning with the things that we can actually accomplish at the state level. So I think for us in Western Slope, it'll be alignment and support. And it's going to just bring a whole lot of organization to a lot of good stuff, but it's needed, absolutely. So it's been great.
Thank you. Any questions about the community conversations? Okay. Next, the other thing that we're going to be offering are opportunities for public testimonies. So we really, again, this comes to our commitment of making sure that we're hearing from the community, and not everyone can be in those stakeholder meetings, even when we open them up to family members and consumers. So also offering the opportunity for people to present public testimonies. So by the end of next week, we will send out calendar invitations so you have these. These are not mandatory for you to attend, but if you want to attend, if you want to listen in, you are more than welcome to. We welcome the participation of our task force and subcommittee members. We have already drafted kind of the guidelines to go out to help get the word out around kind of, if you want to testify, this is what it looks like. We have a flyer that we've drafted. Again, we'll send that to you next week. And we'll ask you to send it out to your community members and really let them know that there's an opportunity, again, for them to share their voice with the executive committee. We've got one member of the executive, at least one member of our executive committee who's hosting each of these public testimony opportunities, and we're holding at least one public testimony opportunity once a month. So we've got our first one the end of this month on August 28th in Douglas County. Then we'll have one at CDHS. Then we'll have one at CDPHE. As we're learning about the executive committee going around the state, we're also looking at providing public opportunities for people across the state as well. So they are physically, you can walk in. You can also call in, video conference in if you live outside of the Denver metro area for any of these. And we will have that technology set up so that people can share from across the state. But like I said, as our executive committee members are going out across the state, we're also looking at how do we set up a public testimony opportunity in Durango? How do we set up a public testimony opportunity in Grand Junction so that we are also being inclusive as we're going around the state? So I just want to put this on your radar because next week you're going to be getting a whole bunch of calendar invitations from me. Just know that, again, they're optional, but we want to invite you to participate if you want to. Any questions about any of that?
Will there be language interpretation services?
Question was, will there be language interpretation services? Well, what we have when you sign up is a question around what kind of accommodations do you need? And so if that's needed, we can set that up.
Is that form available in Spanish?
We'll make sure it is. That's a great question. Thank you for reminding. The question was, will that form be available in Spanish? Yes, question.
Do you have a mechanism for accepting testimony in a non-live presentation, online form, et cetera?
We actually have been talking about that, and actually I'm going to let our communications team talk to that a little bit as well, because they've been working really hard as well on how do we gather stories in different ways. And with that, that is a great segue over to our communications team. So thanks for asking the question. Perfect. Thanks, everybody. I look forward to working with all of you.
Hi, everyone. My name is Mark Techmeyer. I'm Director of Communications for CDHS. And I think that most of you would agree with me that it's rare in your career that you are given an opportunity to change the future of thousands of people's lives. And that's how we feel at CDHS when Governor Polis came to this. We are thrilled to have this opportunity. What we need to do is build momentum. And we need to build the messaging and get it out there. We've got a good start. Our Deputy Director, Maddie Rubel, will talk more about those details, but we need to get that momentum going and get the messaging out there and the stories. The stories are what really sells the message. And so we're going to be asking all of you from time to time to give us a video. Or do you know someone who's a consumer or a family member of a consumer that's willing to get on camera and talk about their journey? Those are what we desperately need. And Maddie will go into the details on that, but I just can't tell you how excited we are that this subcommittee has now started, and we're ready to kick this off. I hope you're all following us or checking out the website, following us on Twitter, all the rest. So she'll give you the details, but anything we can do. We also have 8 different departments whose PIOs are working along with this team to help share those messages as well. PICPUF, CDPHE, DOC, etc. So we're getting strength in numbers, and we need more. And we're always open to ideas. So thanks for being here.
Question?
Yes.
Are you all going to be doing other social media like Instagram, Snapchat, just young adults?
As it develops, absolutely. That right now we're on Twitter and LinkedIn and on our website and Facebook.
Hi guys. Well, I'm going to start just kind of from the beginning. So as you're getting information, I know that filling up Summer's inbox is always an option. Start with the websites. We're keeping that really, really fresh and updated consistently. So if you have questions on your subcommittee meetings or other subcommittees meetings, please check there first. We're also very consistently updating our social pages, and while we're not cool enough for Snapchat yet, maybe we'll get there. So please follow us. Twitter is where we're posting most of our stuff. That seems to be the most timely place to post updates, pictures. I think Carolyn's been taking pictures for it today already. So that's where we'll be engaging with many of you, hopefully, and many other groups. How many of you have been receiving a newsletter from us? Has anybody not received the newsletter? Okay, great. If you're not receiving the newsletter and you just don't want to raise your hand, please come talk to us. It's okay. I know it's the first one. We'll get comfortable. Please come let us know. In this newsletter, this is where we're sending updates. You're going to see some member features. So just to let you know, when you get an email from me, you must respond. There's going to be some important information in there and potentially some asks of you guys to participate so that we can feature you so you get to know each other a little bit better, and other people on committees. I know these are really big groups. We want you to really feel like you know the people that you're working with because we're all in this together. I'm going to touch on media just a little bit. Shannon has already been our star student today, taking an interview yesterday and getting featured in Colorado Public Radio, which was wonderful. We are creating that excitement, and media and the public and everybody really do want to know what you're working on and what you're passionate about and what you hope to see by the end of this year. So as media requests come in, we will filter them to you. If you're not comfortable, please let us know. That's okay. But we'll also help you prep. So if you're wondering what you're supposed to talk about, what the angle is, all of that, we'll have all of that information, and we'll help you talk through your story and the things that you're going to say, because our goal for you is to represent yourselves and each other as well as possible, so that we're all on the same page and singing the same song. Fair? On that same note, if media reaches out to you directly, which very well may happen, I think at most of the other meetings, we've actually had media in the meeting in person. Just give us a heads up. This is not to keep you guys, if you want to let your light shine and be out in front, please speak up and need your voice. It's just so that we can keep track and make sure that we know who's speaking and where everybody's at. The only other notes that I have are just to share our stuff. Please share the newsletter. This is all public information, so share it with your friends, share it with your mom, bring them to the meetings. Just please help us get the word out. If you have more suggestions for us, we're always open to it. So if you see something that you really hate, let us know. If you see something that you like and you want to see more of, same rules apply. We want this to work for you, and we want people to understand the work that you're doing and why you're so passionate about it. I think that was a theme in almost every person's introduction today. It was, you know, here's what I do professionally, but the real reason why I'm here is because this is personal, and everybody has a story, and that's what we're really excited about. With that, we have a video. You ready? So this is as a little bit of a opener. This is a minute-long video, so it's not very long. These are some of the asks that we're going to be coming to you with. This video was actually taken in this room with the Safety Net Committee. And so we asked them, what are your 2 words? In 2 words, describe the work that is being done. And it was just a really beautiful response. So We're going to be asking you at the end of the meeting today what you're most passionate about in this work, either what you hope to see included in the blueprint or what you're just really excited to be here for. And I think this will be give you a good example of what that could look like. So that's just one example. If you didn't catch the theme, it is very hopeful and very excited. So hopefully you guys are as well. You'll notice that some of those people might hold on. Sorry about that. That's okay. So some of them were committee members, and they've been really wonderful about engaging and participating with us. So I know it's very cheesy. I realize that. I'll say that up front, but please participate because it really does make a difference when people hear from you, their peers, and the leaders in this. And where there were a couple people, I think Renee was in that video, and some members of the public too. So as we ask, not a must participate, but please participate. And thank you for everything.
Thanks, Maddie. So with that, we're going to take a little break and stretch. We have 10 minutes planned, so if we could be back at 2:35, that will set us up for digging into some work in the second half of our time together. And for those of you on Zoom, it sounds like maybe there were some issues with the loading of the video and timing of it. So we'll send you the link so you can watch it during the break. So we'll be back at 2:35. Oh, 2:40. That clock is slow. Sorry. 2:40. Back to business. Nobody's listening to me. Let me try on this side. All right. We good? My boss is the only one that's still talking. Shayle's busy. All right, well, she will in a second. I'm going to go ahead and let Shannon jump in. So she and John are going to present a little overview on the assigned readings, and then we'll be able to dig into some small group discussion, reactions to those, kind of framing work together, and really dive in, which is the part that I'm excited about. We've done all this level setting and spent a lot of time getting to know each other, and now we can hopefully turn a corner to start some work. So with that, I'll hand the mic to Shannon. I'm also going to give you the clicker.
Yeah.
Okay.
Yeah.
Let you do yours. Do this.
Yep. Are my slides up here?
Yes.
All right. So as Stephanie was saying, we're going to give you a little bit of a cheat sheet to the assigned readings. This is by no means going to be at the depth of what is actually in the report. So if you haven't read them, I would encourage you to read those documents. But we wanted to go over kind of foundationally why some of these were handed out as assigned readings and are being looked at as foundational documents. So John's going to talk to us a little bit about legislative landscape, for lack of a better word. What I wanted to go over is a couple of reports that were provided in that reading, because the idea is that these were stakeholder processes, some of them several stakeholders that were engaged in trying to come up with recommendations to positively reform the children's mental health system. And so the thinking is we don't necessarily have to start from scratch. We can look at work that has been done historically. And honestly, when I was hearing everyone introduce themselves, there are a lot of things that you guys talked about that some of these reports have recommendations on how to address. And that's not to say that's the right way to do it, but it is at least worth us looking at that. And so we have a place to start where we can say this is still really true. Is this anything we want to build on? What are we missing? And where do we want to go from here? So the first report, Young Minds Matter, supporting children's mental health through policy change. This was published by the Children's Campaign in 2015. It was also co-authored with the Colorado Children's Healthcare Access Program and Children's Hospital of Colorado. There were about 12 other groups that were involved in the writing or served to collaborate in the putting of this report together. It, again, was published in 2015, so it is a little bit older. And so some of these we can actually say we've made progress on, which I think is good. But I do think that some of the things that are in here, we still have some room for improvement on, and so it's probably worth looking at. This one is really focused on policy. And so they were looking at the environment to see what is ripe for change. Where do we actually have opportunities that we think that we can capitalize on at this point in time? And while they mentioned the fact that this is prenatal to 18 in terms of what these policy recommendations would be beneficial for, there really is an emphasis on the prenatal to 8-year-old population in terms of this report. From a guiding principles perspective, when they were compiling this, one of the things that they talked about, particularly as it relates to kids, is that kids are part of a family. And so this idea of like individual-based, treatment-focused, working on the diagnosis with the kid is probably not the way that we should be designing our system, and that we need to be looking at the family unit in which they come with. They also really wanted to focus on, and it was the thing we were talking about earlier, how do we get further upstream and look at health promotion rather than just treatment after problems have appeared? How do we focus on early identification, prevention, health promotion, and intervention? And then they talked about employing evidence-based approaches to mitigating the effects of adverse childhood experiences. They go through kind of the problem statements, or they call them obstacles and opportunities. Again, there's a lot of information in the report about this, but the three main categories of these that they talked about are right here. So when it comes to access and delivery models, they talked about issues with stigma. Again, this individualized focused disease treatment approach and how that is an obstacle and a barrier for kids. That our existing infrastructure is inadequate to do robust screening and diagnosis. And so in terms of identification of things, we have some work to do in our system with that. Coordination of care across primary care mental health providers is not adequately supported, and they talked about a need to help kids that are in crisis.
From a financing perspective, I think the thing that was interesting here, the main takeaway for me was they talked about how our fee-for-service model is really built on the notion that for kids who have a diagnosis, we can deliver service. But for a kid that doesn't have a diagnosis, how do we actually provide those prevention services? What is the funding that exists for us in order to do that? And so they noted that as an opportunity. And then, of course, workforce and system capacity issues. I think we all know that our capacity isn't sufficient to meet the need at this point in time. So that was one of the things they talked about as well. So they had 5 main policy recommendations, but under each one of these, there were maybe 7 to 10 other things that almost are like sub-recommendations or additional recommendations in and of themselves. So again, I would encourage you to go and read the report. But these are the high-level ones, and we can go over them briefly. So they talk about the need to advance integration of mental health services and supports in healthcare settings and educational settings. One of the cool things is we can say that we have actually made some progress on this, at least particularly in the way that Medicaid is administered. So with ACC Phase 2 and the move from the RICO BHOs to the RAY system, and in terms of being able to provide 6 behavioral health visits within primary care, I think we saw some progress being made in this direction in that last Medicaid redo. I think we do still have some foundational problems with physical health services and behavioral health services being administered differently within that system. So we still probably have some challenges there that we can tackle, but positive progress. The second policy recommendation was develop and fund a robust infrastructure to support a statewide screening, referral, and care coordination model. So we did just pass a bill last session that John's going to talk about in a second, SB 195, that did make some progress in this regard. I don't think it solved every single thing in this regard, but it is directionally accurate with what they were trying to get at with this recommendation. They talked about investing in workforce capacity and development. So this is a twofold approach. In addition to trying to increase the overall number of providers, which is obviously a longer term strategy in terms of getting people to want to become behavioral health providers and increase the number of people in the workforce. The need to also really focus on quality. So if you think about it, if one provider is using evidence-based treatment, or we take them from not using evidence-based treatment to using evidence-based treatment, the highest quality treatment, maybe you go from needing to be seen 24 sessions to needing to be seen 12 sessions. You could double the access in the system by just improving the quality of care and making sure that we're using evidence-based research in the care that we're doing. And so they were highlighting the importance of doing those two things in conjunction with one another. The fourth was around developing a statewide navigation system. This is really for caregivers, so a little bit to what you were talking about in terms of it's very difficult to navigate our system and gain access not only to mental health services, but other resources and supports that would be needed. And so really trying to make sure that we are able to connect our caregivers and help them navigate that and be successful. And then, again, things that were mentioned in the introduction, we have a lot of pockets of innovation, amazing work that's happening across Colorado, but it's happening in pockets. And I think really what we're wanting to do is try and create a system. And so how do we take those promising practices that show demonstrable results and actually resource them to scale them so that every kid in Colorado has access to those services? And so that's kind of what they were getting at for recommendation. All right. The second report is the Roadmap to Children's Behavioral Health Systems for Children, Youth, and Families 4-Year Strategic Plan. This was published by Partners for Children's Mental Health, so if I get long-winded, you can just tell me to sit down. This one I can talk about for a long time. So the purpose of the report is on the screen, but there was a secondary purpose in terms of why this process was undertaken and why this report even exists. And it's kind of a precursor to what it is that we're doing here. I think the realization among the advisory council members at Partners for Children's Mental Health was that there's a lot of people trying to solve this problem, trying to crack that nut and be like, how are we going to fix the children's mental health system? And the idea being that if we can get aligned around like the strategies that we're going to employ and all start trying to solve the problem in the same way and say, hey, this is the way we need to do it, and we all start going out there to implement that, but the progress that's going to be made is much, much faster. And so the goal was to try and get as many stakeholders together as we could to try and create that sense of alignment and push positive reform forward. So we had pretty broad community engagement. We had 117 stakeholders repeat and participate in multiple work group sessions around how do we fix the children's behavioral health system in Colorado. We also had 124 stakeholders participate in terms of giving us public comment before the report was published. I'm not going to go over these in details. We had overarching guidelines. A lot of that was around let's not duplicate things. Let's not reinvent the wheel. Let's look at what's already working, how we take that to scale. Let's make sure we're engaging families and youth with lived experience, that we're coordinating efforts. And we also focused on honoring and operationalizing system of care values and principles. So from a process perspective, and I'm interested to see how we approach this as a task force, when you're getting together 117 stakeholders and saying, hey, how do you want to fix children's behavioral health? Like, where do you start that conversation? And so we went out to the resource search to try and look at like, what's a good way to do that? And there were things out there that said, okay, here's the 20 plus things that you need to like consciously think about when you're designing a children's mental health system. And if you don't consciously think about how to design for that element, like screening, and you just allow that to happen, then you probably don't have a very good system. And so we took all those topical areas, we split the work into 6 different work groups, and we tried to put each one of those things in a work group to be addressed. And so we had 6 working sessions for each of these work groups to look at each of those areas to try and look at the comprehensive system design. We tried to do this on a consensus process. Obviously, you don't have unanimous support for everything that you do. And so with all the stakeholders that participated when we put it out for public comment, we allowed people to say, I support this recommendation, I support this recommendation with modification, or I don't support this recommendation. So our most contested recommendation still had 85% support. And it was around like a creation of an office of like culture of diversity and something else, which I was like, that's interesting. But you read the comments and they felt like it already existed elsewhere and that it would be duplicative. So I was like, and you know, this was among state agencies, local agencies, provider organizations, advocacy organizations, youth and family themselves. And so when you get to that level of agreement that like, oh, that recommendation rings true, I think we felt pretty good about what had been put together. So there were over 30 recommendations that were put out, and I'm not going to review 30 recommendations with you today because we all want to leave and it's Friday and get to our weekends. But I did want to highlight like 10 of them for you so that you could kind of get an idea of the types of recommendations that you're both looking at. And again, you can read the report and get a lot more information about what people said from a consensus. If they didn't think so, what was the dissenting opinion and what did that look like? So from the governance work group, one of the biggest recommendations that came out was that we needed to establish, and this is kind of the idea of breaking down the silos, a centralized governing body with authority, clarity, capacity, and credibility to govern the system. The idea here being that if every state agency has some amount of responsibility for administering the children's behavioral health system, nobody has fundamental responsibility. And so when that kid is falling squarely between the cracks, where do you go have that conversation? And so the idea was to try and answer that and say, we need a governing body. Either you put together an agency that has responsibility or you put together a body that has responsibility. From a financing perspective, one of the first recommendations to come out was to create a financial map so that we can understand the system in relation to prevalence, need, utilization, and cost. The idea here being that resources are limited. Let's see where they're being spent. Let's make sure that we're maximizing federal dollars. Let's make sure we're not duplicating services across systems. And so really understanding where the dollars are going would really allow us to make better informed decisions on how we maximize those resources, whether or not there's other opportunities to bring federal dollars into the system to maximize the state dollars that we're putting into the system. Another recommendation from the finance group was to execute a pilot project that blends and brings funds of relevant child serving systems in a joint funding venture. So for youth that are multi-system involved, having each agency be like, well, I'm going to pay for this piece and you're going to pay for that piece doesn't necessarily make the most sense. And so there's a lot of other states that have done really well these blended and branded funding models for those types of kids, where we're no longer having creative solutions calls for 8 weeks about who's going to pay for what, and that we just like pull that together and we serve the kids. And so that's the idea behind that recommendation. Quality improvement reached consensus on a core set of indicators and outcomes. So Indiana has a really cool model of this. Every kid that needs more than those 6 visits in primary care has the exact same assessment that's done on the entire state of Indiana. This includes like social determinants of health. This includes what's going on with the family. It's not just about, what's going on from a mental health perspective. They force it to be re-administered anytime a kid needs a change in the level of care every 6 months, and it discharged from the system. Can you imagine the power of the database that is for system designers? Like, what are we seeing? What are the biggest needs there? Is it transportation? Is it, and where is that at? And we can look at it in pockets, and we can even look at outcomes. Like, oh, people in this provider organization are staying there for a really long time and nobody's getting better. And so now all of a sudden you have a report card that you can use. And so the idea is to come up with a core set of data that we collect on every single kid in the children's mental health system that will give us data that we need to make informed decisions about the health of our system and how we need to be doing from a design perspective. Support evidence-based practices and core competencies. So again, that's what the other report was talking about in terms of there's 2 ways to tackle access issues: increase the number of providers, which I think we all know we need to do. But if we improve the quality of care that we're offering and kids are not in treatment for 2 years, we can also create more access in the system that way as well. Care coordination, develop a statewide tiered care coordination model. So SB 195 does a little bit of this in terms of trying to take wraparound statewide and make wraparound available. But the idea here with this work group was there's something between wraparound, which is a really intensive form of care coordination, which is 10 kids for 1 care coordinator, and managed care, which is like 1 case manager for 300 kids. So with the idea being that we should have a tiered approach to care coordination based on the complexity of the kid that matches what's going on with that family and is working and helping them navigate the system and get their needs met. Service array, one of their recommendations was to improve the data metrics for measuring and reporting on network adequacy. So a lot of times we see things around network adequacy that are just like, do you have this service available? And it doesn't talk about the fact that it's like a half of FTE that works on Thursday afternoon. So the idea, being that we look at capacity of these services in addition to them existing, but also need to understand what the need is for that service and whether or not the network is adequate to support that. Develop a core set of service strategies, services, resources, coordination, supports be made available statewide. So the conversation around this with the work group was around, there aren't a ton of things that are statewide available because so much is locally administered in Colorado. You have individual school districts doing different things, individual schools doing different things, individual child welfare county agencies doing different things. And so that we should come up with like a foundational, every kid in Colorado should have access to. And once we come up with that, then make sure that we like get that rolled out so that every kid, and that doesn't mean that we can't still have localized programs and localized things, but we should have a foundational, from a service array perspective, every kid in Colorado should have access to. And then the last 2 work groups, access, screening, and assessment. So establish a universal and standardized approach to screening. We have a lot of screening that's happening that is not using evidence-based tools. We have a lot of people that are doing this that don't necessarily know how to administer these screenings. And so how do we make sure that we have a robust system in place to do that? And then this talks about both establishing a no-run door as well as kind of this idea of a single point of entry. So you don't want people to be like, oh, this isn't where you need to come. Like they should be able to come in any door they are, but then also if a kid shows up for primary care, what's our answer to primary care in terms of where you should send that kid? Okay, I did the screening you asked me to do. They have a need, now what? And so that's the idea of creating that single point of entry. So that's just 10 of the 30 recommendations from the stakeholder process. This is less than a year old that we did this. And so this is something that's still relatively recent. And some of these are being, progress is being made on and others are still waiting for action to be taken. So again, we don't have to start from scratch. We had this stakeholder processes that have existed for these 2 reports. So we can look at these and say, do any of these resonate? And it might be no, or it could be yes, but at least it gives us a starting point for us to respond to. And so we'll need to go through a process by which we give everyone the opportunity to have voice into that. I think we were talking about maybe a survey process or something like that for folks to be able to weigh in. We also know that we probably don't have every foundational document. And so we need your help in terms of what are the other large stakeholder processes that you guys have visibility to that we need to send out to everybody and read and add in to that looking at things. We don't have as much on early childhood and prevention and stuff here, so we probably need some more reports around that. And so if folks have visibility to that, that would be helpful. So that's all I had. John, do you want to share?
Well, we do have time for a couple of questions for Shannon as we make the transition to John. I know we have one on Zoom, but also in the room. Why don't we start here and then I'll come down the line.
So Jamie sent in a question by chat, and it is related to the roadmap report. The youth voice presents some key findings that are particularly revealing relative to school-aged children, and she's wondering the number of youth that completed the survey.
It's a really good question, and I would have to go back to the team to ask that.
Okay, we can follow up with her.
Yeah.
I'm just curious, with the amount of focus on assessments and level of care, what are touch points, this group's touch points with the Family First Prevention Services Act groups are? are so that we're not duplicating that work?
Yeah, he's going to talk about that. So when we were doing the roadmap, we were working really closely with the consultants that were leading the Families First process as well. And so we did have a lot of between our groups that were working on this process and their groups that were working on that process. And I didn't mention for the roadmap, it was staff from the Office of Behavioral Health and staff from Partners for Children's Mental Health that facilitated those. But then we also had co-chairs similar to this type of process for each of our work groups. And that was folks from HICPUF, Children's Hospital, Cigna Behavioral Health Network, the Office of Behavioral Health, and Unfolding Directions. So just for what that's worth.
I'll try to get to you.
Just loudly. Those are little mics. I can be loud.
Okay, this microphone for the group is starting to blink, and 2 is ready for the weekend. So
So on the legal front, as a lawyer in the group, my concern, my question would be what safe to tell or those other state or local mechanisms, how that data is incorporated, because of course some of this is an educational record and then we have HIPAA and we have all of that. So at the outset, do we know if we have a good system to aggregate, delineate between duplicative reports and also make sure we're getting everything?
Yeah, I think it's a really good idea that we should look at all the data sources that exist out there and figure out how can we, at least especially for the work group of this work group, to say what is the data that exists in today's system that we can get in terms of getting our hands on things, figuring out what we know and what we don't know, and what we still need.
Just to follow up to that question. So we're looking very deeply into what's safe to tell. It has right now and has the capacity to grow to Safe UT, which is the Utah's knockoff of our Safe to Tell. Actually has a really interesting way that they have changed that program that we're going to look at and see if it makes sense for Colorado in terms of where do the reports go to, how are they filtered out to law enforcement as opposed to filtered to mental health, referred from mental health to. Anyway, so that's coming up in terms of research that we're doing right now.
The other point, just to touch on that, is HICPUF had some TA funding to help us sort out how to navigate between FERPA and HIPAA. And there is a guidance document that was just created. It has not rolled out yet, but there's some training that's going to be coming to address just how doctors even share with it, HICPUF. So I'm sitting on the committee for that, so you can reach out to me. It will be shared. It will be disseminated. Is OBH actually going to do some training on that? Are you aware of that at all?
I don't know.
Okay.
But I was hoping that would also include 42 CFR, which is on the substance use side.
Yeah.
Because that's a whole different quagmire.
Yeah. So we can get that information disseminated.
As we move forward on this task force and are looking to not necessarily start from scratch, are you going to bring in speakers from other states or internationally somewhere that might have some innovative practices that they're already using?
Yeah, I think we absolutely can and should look at.
Just giving you a mic signal.
You want me to get it closer? Yeah, I think we absolutely can and should. I think we as a task force need to figure out what are the areas of information that we want, and then to the extent who has the expertise to come provide us with that information. Yes.
Along those same lines, I just would also say a couple of things. One is, while we don't want to necessarily start from scratch, I also want to just keep in mind that everything is on the table. Anything's on the table. Whatever we want is on the table. There he is. And so I wouldn't want us to go too closely to historical documents that may not necessarily be from the perspective of if we could paint a picture exactly how we wanted it. So that's one caution. And the other is that having spent some time in the Medicaid office, I know that the adage is true. If you know Medicaid in one state, you know Medicaid in one state. Right. So when we start looking at bringing in people from other states, we have to keep in mind that the way that funding works in Colorado is the way that funding works in Colorado. And so what what Washington State is able to do and be very successful doing is also very specific to their state.
Any other questions on that? And thank you, Linda, for that. I think, you know, one of our preliminary readings we even had was, you are here because you are an expert, you know, at some level. And we obviously know we don't know everything, and I as one person don't know everything, but the group of us probably know a whole lot. And we know our state, we know our funding streams, we know the barriers, we know those things. And so at some level, we are the experts, and we really want to speak with that voice. And so, thank you. So, first legislative consideration. I am going over this not as a sense of that you will track all the details of these laws and what has happened, but just to give us a little bit of some, you know, if we're fumbling around in the dark in the room, where's the recliner, where's the couch, and where are the stairs to the basement, right? And so there are some things at a federal level that we just have to, or we're in the process of complying with, or we're in the process of rolling out, and then we'll get to the state, and then some just thoughts as we think about what we want to recommend if we had a completely blank slate. So FFPSA has already been mentioned. This is actually, the target date is January 2020, so coming up very soon here, that this is going to be live. It covers both ends of the spectrum, from prevention services to congregate care. And so again, I'm just giving a very high level summary of this. One of the things I want to highlight is that one of the requirements that they have a clearinghouse to identify evidence-based services. And so this is a federal clearinghouse that will be looking at services that the state presents to them to say, yes, this is considered evidence-based, a promising practice, et cetera. And so this is a work that seems to align with one of the recommendations and a tool that we can use as this gets further rolled out. Right now, there is a website for that clearinghouse if you want to look for that. And I think 9 practices have been approved to date. And there are more that are just going to be continuing to go. So if you have a local practice, a local therapeutic intervention, a local, you know, something that you're aware that you want to say, hey, can we get this on the clearinghouse? By all means, anybody can submit that.
Oh, no, I was just looking at Ruby. I think the number is a little different, and the clearinghouse itself. The feds have formed to the states to develop our own clearinghouse.
So can you speak to the process? Do we submit to the clearinghouse? We submit to the feds for approval?
So CDHS will be looking at what EBPs will be the most appropriate to use, and then the feds, through their own process, will kind of deem CDHS as being in compliance.
Okay.
Yeah.
Perfect. There you go. Thank you. ACE kids. So this is advanced care for exceptional kids. There is an effective date around 2022 for this. As it relates to our interest, the consideration that a serious emotional disturbance or serious mental health condition or diagnosis does qualify to be a participant or to be affected by that enhanced pediatric health home. And so that means that that advanced health home will be doing extensive care coordination, family support, community-based services. And so that's the federal law. Okay, you're smiling, so that makes me think you're really enjoying this.
No, there's just lots of ACEs out there.
Yes.
It's confusing.
Yeah.
And then the Support for Patients and Communities Act, that's kind of the shorthand for it. This is a substance use bill that is coming out, again, looking to start. There are different phases of this. 2019, so coming up pretty soon. A lot of this actually impacts Medicaid specifically, what we can or cannot do, how we either apply or reapply Medicaid for certain at-risk populations or youth, et cetera. But I just want to highlight that this is another federal law that we're working to organize. And I think one of the things that's helpful for this group is the idea that the goal is to strengthen the workforce, right? And so with trainings for providers, primary care providers, other providers on substance use, abuse, prevention. And so there's some initiative that's going to be happening with that piece that might be supportive of what we're doing here. Current landscape in Colorado. So if you were aware, there was a lot that happened in the legislative session this year. And so, yes, I highlighted, of course, a very important bill that was passed. I'll mention a few here. First, obviously, is parity. Well, let's see, is that? Yes, that's the first one, parity, which we all know that. We've all talked about that. We've all wanted that. And how that's going to be worked out, I think in the main task, or the task force itself, there was a presentation on that, and that there's going to be monitoring of parity. And there's going to be, if it's harder to get an appointment with a therapist than it is with your doctor, that's not parity, right? And so how are we going to do things differently? How are we going to track that? What can we do to ensure just access to an appointment? If you have to wait 3 months for a child psychiatrist, but you can get in to see, you know, a cardiologist in less time, that's not parity. And so again, we're glad that passed, and now there's a lot of work that needs to go into implementation. HB 191120 changed the age of consent for a youth seeking behavioral health treatment to the age of 12. Thank you, Representative Michelson. And so that should impact our work as far as how we're able to get kids into care and services as they need that. HB 191017 creates a pilot program that actually dedicates a school mental health professional to each grade K through 5. Think about, think about the impact that that pilot project, and depending on, you know, how we could expand that intervention would be. 1139, it transfers some funding from HICPUF to DHS for a high-risk families cash fund. And this is to address postpartum women to be able to, one of the components of it is to give or to seek federal authority to allow postpartum women to enroll in Special Connections. Special Connections is a program that's designed for to promote healthy pregnancy. It does have a focus on substance use and abuse, but it's restricted right now that if you're not enrolled while you're pregnant, you can't enroll after you deliver. Yes.
It's 1193.
Oh, I transferred the numbers. 1193. Thank you. And then SB 19228, OBH will purchase evidence-based substance use prevention services from a community-based youth development organizations, with the idea that there will be some training to merge substance use services with OBGYN services. So women who are seeking substance use treatment, intervention, can also access physical health services in the same setting. And so again, there's just a few of them that I think might inform kind of the landscape that we're looking at and what's been done. Additionally here, CDHS is working on a document that will summarize from the last 3 years legislation that has been enacted, that we can look at to see where things are moving or what has been done that might impact what we're looking to accomplish. The big one, though, which was in our binder, is SB 195. And I don't know if there was an actual official title of that bill. Was there? I've seen different ones, but
Child and Youth Behavioral Health System Enhancements.
Okay, so sorry for the error there. Perfect. I couldn't find it on the actual bill itself or whatever. That's right. Thank you. So there were 5 main objectives, goals with this. We've touched on a little bit the idea of a funding pilot that braids and blends, funding for children who are in those multi-systems. So in this system where different agencies maybe are playing not it or hot potato with some of that. How do we, let's pilot something there and see what we can do to fix that piece. The idea of a statewide screening tools as well as statewide assessment tools is a mandate there. And then the single referral and single entry point system that is going to be designed, that will be a statewide system that we could use so that we eliminate a lot of the wrong door kind of approach here that you currently see. And then the implementation of high fidelity wraparound services that would mandate that the RAIs and the managed care entities participate in that and provide that. So this was put in our binder for reading material just because this is definitely a comprehensive piece of legislation at some level. It crosses multiple systems, multiple silos that we've talked about. And so in many ways, it's up to us as a task force, a subcommittee, to say, how can we help steer, guide, recommend implementation strategy? Is our vision, if everything is on the table, is our vision consistent with this? Or is this, something that we want to, truly help endorse and support and push forward? Obviously, some of the other smaller pieces, we might impact some design pieces, depending on how it may align or not align with what this committee decides. And so it's just really important that we understand this legislation specifically. And here's just some thoughts, closing thoughts. Obviously, we have federal law, state law, and statute, and you may know from your practice, your sphere of expertise, you keep bumping into this statute. You keep bumping into this law that says I can't do X, Y, or Z. And so I just want us to be thinking about that level of it. I mean, yes, we have system concerns, but there's also laws and statutes and things that have passed that tie your hands or prevent you from doing something. Clearly, our current system over the last 20 some, 30, however long it's been in place, has been a piecemeal patchwork process. And that's not stopping, as we have heard. And I'm sure from those of you in larger departments, organizations, we have a legislative agenda that's going to go forward. I mean, there's many of you might be participating in legislative agendas that are already going to start in January. And so we're still in that same mode. And so the challenge here is, can we move away or maybe supersede this patchwork special interest focus to a broad vision? And so I want us to step back and think as tall and big and high as possible. And maybe that is agreeing on some philosophical structures first, or maybe that's agreeing on the values and priorities that we want to see reflected in the actual details and structure and systems that we create. Maybe that's one way to kind of get some of that broad perspective there. So just some thoughts. Obviously, we've already mentioned these things, the duplication, the silo, the territorial components of this. And so one thing that came out at the task force on Wednesday was from Raoul and the Western Slope region. And some of the concern there is that some of these communities have actually found some solutions. They've created some systems. They've figured out some things, and they don't want us to disrupt what's working well. Obviously, there's no guarantees, right? Because if we're doing statewide work and cross-silo work, we may have some disruption, but obviously just want to be sensitive to that voice. So, any questions?
I mean, I just hesitate to say this, but are we going to actually make recommendations to change federal law?
Well, it depends on how we go about that. I mean, there are waiver options, right? If it's a funding issue, I mean, if we're talking about Medicaid, or how we could potentially get a waiver for, something that is restricting us. There's some of these federal laws we obviously have no authority to do, or so if someone knows how to navigate federal, waivers or other things like that, I will say that's big enough. I like how you're thinking.
I know how to navigate waivers.
Yeah.
Over the place, but, I mean, one of the things I'd love to change is EPSDG from birth to 25.
Okay.
Given what we know about brain development, given what we know about youth with mental health challenges, if we could expand that from 21 to 25, but that's like changing Social Security. I don't know. It'd be nice.
Dream big. I like it. Yeah. Any other questions? Okay.
Can we pause to see if anyone on Zoom, any of our subcommittee members on Zoom have questions?
Yes. Is there anyone on Zoom who has a question?
All right, John, Shannon, thank you. What we really want to move into next is going to be time for you guys to actually talk, really get a little bit of work done. And I will say that today, you had to bear with us just a little bit. There's a lot of kind of housekeeping and level setting and making sure that we're all on the same footing moving forward. Okay, and we've got a limited time over the course of a year to get this going, but I can guarantee you that we will flip this to a certain extent, that the conversation is going to come more from you and less about presentations than it is about really sort of rolling up our sleeves and getting the work done. Today, we've got a limited amount of time, but we want to tackle a couple of things that are really important. The first is going to be thinking about, really how do we begin to prioritize what the big issues are to you. So we're going to take a few minutes in small groups so that you guys can throw those out there. And whatever's like the most important thing or what you would want to prioritize, let's make sure we get that down on paper. And this is just a starting point. It's an entry point, but we want to make sure that we begin there. The second thing I think is equally as important, and that is thinking about our subcommittee specifically and essentially how we feed into the overall task force. What does success look like, right? How are we going to be able to look at what we've done and say, yes, this is how we're going to measure ourselves and know that these are the successful steps that we wanted to take to be able to feed into the overall blueprint, okay? Those are the two questions. They're in your handouts and that sort of thing as well. I'm going to start with Lindsay over there and have you run the room counting 1 to 5, and we'll break you into small groups. Yes?
Yes. I just wanted to do one little piece of housekeeping in addition to that. On the worksheets, we'll collect them. It's been a really nice way with the other subcommittees for us to be able to get your feedback. So if at least one person in each small group could be jotting down notes, we'll have an opportunity for report out, but we always get much more rich information from those worksheets than we do from that, or in addition to that, it's helpful. So please use those to record your work.
Because even in small groups, it's hard to get everything said. So if it's said and it's important to you, write it down. If you didn't get to say it, write it down. And then we always will collect all of that.
And then the other thing, sorry, Shale, is that we did create a space for members of the public to have your own small group in the back. So you won't be counting off by 5, you'll all be in one group together.
Just gonna count off the task force, starting with Lindsay.
Thanks, Shale.
1, 2,
3,
4, 5. 1, 2, 3, 4, 5.
1,
2, 3, 4, 5. 1, 2, 3, 4, 5.
Okay, so one's going to start over here in the corner, and you'll find your numbers around the room. 1, 2, 3, 4, 5.
And groups 1 and 5, bring your chair because you're kind of in the corners.
That's okay. 1 and 2.
Sheila and I go back to, how old were we?
I don't know.
20s. Yes. We were 20s. We're group 1, and I'm going to try to organize this under a couple areas. One was a discussion of decreasing barriers. So I think we focused on priorities. Hopefully success will answer some of these priorities because we didn't really get beyond question 1. Decreasing barriers, having a system that is more integrated and has a decrease of bureaucracy with a high degree of collaboration, having systems with increased responsiveness and that are more adaptive, decreasing barriers around shared information and less hiding behind by HIPAA other issues that various people have experienced in different contexts, and decrease financial barriers, having more parity between private payers and Medicaid, perhaps not just having Medicaid fund behavioral health for the private payers who aren't coming to the table, and potentially even having a system that is blind to that from a parent-family perspective, that while the state might sort out sort of private public monies, for a family it might look the same. And then the second piece was having high accountability of public money. I think that has been seen as an issue to date, that there's public monies going to certain places without high accountability, and liking that to be more transparent and accountable. Did I miss anything, guys? That was
Family-friendly court. Yeah, these guys sort of shaped things around what they thought were big ideas. So that worked really well. Thank you. And overcoming the barriers, seeing it from our patient and consumer perspective to be able to really achieve the care that they need, critically important. Thank you. Okay, who's reporting out here?
Hi, everybody. So our group talked a lot about various ideas and priorities, big issues. So in terms of kind of bucketing these, We talked about financing, making sure that we can pay for services across both Medicaid and private pay, having access, so no child in Colorado should be without mental health care, especially in the schools, and finding appropriate ratios and services available. That also goes into workforce development and high quality services available for patients and families. And I think our biggest priority is thinking about infrastructure and having a statewide system that would allow us to de-silo the services and really provide a continuum of care, as well as a warm handoff, or I like to call it the hot handoff, giving patients and families access directly to the next service and the next person that's going to help them, and maybe having some case managers in place to make that happen. And we really would measure success with obviously good, concise, measurable outcomes, and a system that we can understand, but also that lay people and our families and communities can understand as well, and know how to get in touch with. So really that no child lacks the care, and doing away with that narrative of this is how it's always been done, or this is the way that it's happened forever. We have to keep doing it that way. We want that to be our success point, that will no longer be said.
Thank you. Okay. I'm headed to you guys. You can read that.
Sorry, we had it right there. All right, so some of the priorities that we looked at was making sure that we're funding for wellness in addition to wellness, and having a philosophy shift, not just to look at what the needs are, but also what the strengths are. So lots of resiliency building and health promotion. We also want to make sure that there is a single point of entry that is designed to succeed, rather than just serve as a empty sort of slot for folks to check off. Making sure that screening assessments look at both strengths and needs, as we talked about earlier, and making sure that we are looking for statewide solutions, understanding that each locality is going to have some difficulties in terms of implementing some of these things for sure, but the importance of having something that is across the board, I think, will be important. So,
Success would be fine too.
and then just because I'm up here, we'll talk about the successes. So making sure that we have a clear map for process flow from identification to system discharge for youth. So the idea here is how does a person go through this process clearly laid out? If we get the design, that would be fantastic. Actionable recommendations that are actually implemented with accountability that include timelines and goals, etc. And then cross-systems data to inform system design and effectiveness, unique identifier for youth across systems. That way we can all look at the same data and make sure that we're extracting similar conclusions.
Thank you. I hope we can get to that last one. That would be good. All right, who's up here?
Okay. Well, we talked a little bit about wanting some more information just about what our parameters were. So who are we talking about? What age are we talking about? Which would direct our priorities, definitely. But some of our big issues include paying service providers a better livable wage. I think just having all of these ideas of what else we can do is great, but not if we don't have people to do those jobs. And then we also talked about more accessible care in the form of affordable, but also geographical. So not having Denver or the other cities be the place to go, but having more places across the state. And then looking at the limitations of a single entry point. And I might have Lenya speak a little bit more to that.
What I talked about was just a concern that when we think about a single entry point, or what could also be an administrative service organization, you just put one more layer of bureaucracy between the individuals who need service and the people that are providing the service. So I know that if we think about the people that are here representing as parents or as people who have actually utilized our services, I feel like they want less bureaucracy. and more access to care. So I would hope that if I had to be a perfect picture, I would say government needs to get out of the way of the providers doing their job.
And then the last two that we have are to prioritize LGBTQ care, as our queer identified youth are really struggling right now. And then additionally, making sure that youth voices are present for these conversations.
Thank you. I appreciate your raising the potential for unintended consequences when it sounds like we're putting in a good first step, and additional bureaucracy could be an outcome that was not where we were headed. Okay, who's up?
So one of the downfalls of going last is that all the other groups have covered a lot of what we've put down on our paper. So I will just cover the areas that I didn't hear a lot of. One of the areas that we'd like to prioritize is just looking at mental wellness as a whole, which covers social and emotional, workforce, education, juvenile justice. Making sure that we invest in prevention so that we can prioritize all youth, and we've identified the ages prenatal to age 26. And we also talked about wage increase for the next generation of professionals and enhancing their training and education so that they are really effective and they're culturally competent, meeting the needs of all youth. And some of the areas what success may look like is incorporating evaluation throughout this entire process so that we could always check in to see what data looks like, tracking data, making sure that we see a reduction in the issues that matter most to this committee, like suicide prevention. We also talked about developing some pretty hardcore policies that leads to increased funding, community investments, so that we have a strong future for youth in Colorado. And that clients within the system report back and say that the system is working.
Thank you so much. All right, I'm going to turn to Bob Morgan on the, no?
Brooke.
Brooke?
Yeah.
Oh.
Brooke, are you out for the working group on Zoom?
Right, can you hear me?
Yes.
Okay, great. So a lot of what has already been talked about, and particularly that focus on upstream prevention efforts, decreasing that long delay between symptoms or difficulties or experiences are identified, and the services to help prevent further disruption, decreasing roadblocks and barriers to services, including when Medicaid and private insurance are involved. Focus on wellness, which many have talked about, as opposed to only behavioral illness. Really ensuring that there are culturally sensitive services available and that there's the training of the workforce to make that possible. And making sure that we have culturally competent providers both in all communities, big cities and in rural communities. Working across systems and really decreasing some of those silos. We talked quite a bit about the importance of engaging nonprofits and other kinds of providers, hospitals, state agencies, and other agencies and systems where children and families are, where we can reach them, like schools. We talked about the possibility of that social emotional screener being more widely implemented, and really a lot of energy around ACEs and preventing ACEs and their impact in Sequelae, strengthening the protective factors that will ensure success and healthy outcomes for those kids. Success for the subcommittee, I think we all agreed, timelines with action items that are clear and concrete steps, and really a focus on that whole community health to help with the connection and the alignment amongst agencies, and really strengthening those community-based solutions, connecting grassroots solutions with strong state support. We talked about single and non-variable funding sources. We talked about youth-centered processes and solutions that strengthen wellness and put that over the convenience of systems, and then equitable attention to both rural and urban issues and solutions.
You guys got through a lot online. Good work. I think one comment that I want to make is that it's reaffirming that many of the big ideas and the measures for success are similar from the other subcommittees that we've been working with and the task force overall. So people are on the same page with identifying some of these barriers. And so we'll be trying to bring some of that together. I'm going to turn now to our folks from the public for sort of a general public comment and your report.
We had many of the same things that you already talked about, focusing on screening, a definition of medical necessity, making sure that we are not missing critical components with the screening tool, focused on upstream, doing some sort of gap analysis to figure out what are the gaps in treatment needs for youth, and then also focus on co-occurring issues. As far as success, that we will have policy recommendations that can be put forward and implemented, with caution though of unintended consequences from those policy recommendations, which I think is what Lenya spoke to. And then strength would be that we have a sustainable quality workforce that provides quality care and that isn't that we're retaining them, so that there's not only do we have enough, but they're not leaving and going on to other things, so that clients can keep their provider.
Are there others who would like to offer public comment before we close out our meeting today? Anything else you guys want to add? All right, thank you for being here. Appreciate it. I think at this stage we're going to turn it to Summer. Is that right? To Shannon. See, just when I don't have my agenda in front of me. Shannon, it's all you.
No, I just wanted to thank you for your time today. I know it's been 3 hours on a Friday. We went through a lot of housekeeping items. We talked at you a lot, but really appreciate your engagement in this. We can see the passion in the room. Really excited to work with you and do something meaningful for Colorado kids. So thank you. See you guys in 2 weeks.
Thank you. And there were a couple of just reminders about notes being circulated, slides being posted, and that our next subcommittee meeting will be on the 23rd. So we'll see you in 2 weeks and appreciate your time. Thank you.